Good morning, everybody. Welcome to Grand Rounds. It's my great pleasure this morning to introduce our speaker, Dr. Barry Greenberg. Dr. Greenberg is Distinguished Professor of Medicine and Director of the Advanced Heart Failure Treatment Program at UCSD. He earned his medical degree from the State University of New York Upstate College of Medicine in Syracuse, and completed his internship at George Washington University Hospital and residency in internal medicine at Yale New Haven Hospital. Following research training at the Lipid Metabolism Branch of the National Heart, Lung, and Blood Institute in Bethesda, Maryland, and the Cardiovascular Research Institute at UCSF, he completed a fellowship in cardiology, also at UCSF. Dr. Greenberg's clinical research focuses on understanding mechanisms of cardiac dysfunction and developing new heart failure therapies. He also directs a basic science laboratory that studies the molecular basis of cardiac remodeling, myocardial fibrosis, and the development of novel therapies. He has published extensively in medical journals throughout his career, and in 2017, in recognition of his accomplishments, Dr. Greenberg received the Heart Failure Society of America's Lifetime Achievement Award. We're very fortunate to have him here with us this morning. He's going to be speaking to us about lost in the middle, managing patients with heart failure with mildly reduced ejection fraction. Dr. Greenberg, thank you.
Thank you, Simmerjot. It's a great pleasure for me to give this talk to provide Grand Rounds for the department, which is my home department here at the University of California in San Diego. Here are my disclosures for this lecture. And what I'm going to be talking about is a cohort of patients with heart failure that really has not been well understood and certainly not well studied over the last several years. And I think that there's a lot that can be said and done with this population. The subtext, though, is perhaps even more important because what I'll be looking at is the way that we evaluate patients with heart failure and how we classify them. And I think there's a lot of room for improvement in this area. So what I'll do is start out by defining heart failure with mildly reduced ejection fraction and talk a little bit about the patients that have this condition as well as their clinical course. We'll look at the way we classify patients with heart failure, which is currently based on left ventricular ejection fraction, and talk about whether or not that may be the best way of doing it or perhaps not. And then we'll go on and talk about the management of patients with heart failure and mildly reduced EF. Throughout the talk, I'll be weaving in some future directions, but I'll give some specific examples at the end of the lecture. Well, let's start out with a historical perspective. And back in the 1980s, heart failure was synonymous with abnormal systolic function. 2D echocardiograms had become widely available, and one could easily measure left ventricular ejection fraction. And that became the gold standard for evaluation of patients and also began to be used to classify these patients. Clinical trials, which were really starting up, the large-scale clinical trials that ultimately gave us direction in managing patients with heart failure, recognize that one of the ways of making sure that patients who were enrolled really had heart failure was to mandate that they have a left ventricular ejection fraction that was below a certain level, and an arbitrary level of 35 to 40% was selected. And this selection also enriched the population for clinical events so that these studies would have adequate power in order to test whatever investigational therapy was being looked at. The randomized clinical trials that use these criteria, which were performed back between 1980 and 2010, really were critical clinical trials in both confirming the neurohormonal hypothesis, but also giving us a variety of very effective therapies for the management of patients with heart failure that were disease modifying, particularly the ACE inhibitors, ARBs, beta blockers, and the MRAs. And these all became first-line drugs for managing patients with heart failure. However, it also became apparent that some patients developed heart failure without evidence of reduced ejection fraction. This is one of the earlier, or a photomicrograph of one of the earlier studies. This came out of the Oregon Health Sciences University. The senior author was my good friend and colleague, Dave Bristow, in which they first described the small stiff heart syndrome. And obviously, this patient does not have cardiomegaly and does have evidence of heart failure on the chest X-ray. So heart failure then became partitioned into those individuals who had reduced ejection fraction and those individuals with the small stiff heart syndrome that had that same clinical syndrome of heart failure, but left ventricular ejection fraction was preserved. Based on the success of the clinical trials with neurohormonal blocking agents that had been carried out in patients with heart failure with reduced ejection fraction, many of these same agents were also tested in patients with preserved ejection fraction. However, virtually all of these tests were negative, and these results substantiated the differentiation and classification and suggested that heart failure with preserved DF was indeed a very different entity from heart failure with reduced ejection fraction. Notably, throughout this period, there was little or no mention of patients who had heart failure in the range of an ejection fraction between 40 and 49%. So what the playing field looked like, and this is a histogram of a population of patients with heart failure. You had patients with reduced ejection fraction. You had patients with preserved ejection fraction. And then you had this group in the middle that nobody was talking about. We knew very little about these individuals, and they were not included in the large-scale clinical trials, and they were just sort of there. And I guess you can say that mildly reduced ejection fraction really was not getting very much respect from the heart failure community. Well, is this an important group of patients? We can start out by saying, and there are now a number of surveys that document this, that it is quite common, and somewhere between 13 and 24% of patients with heart failure have an ejection fraction that lies between 40 and 50%. These individuals, as I've already mentioned, were largely excluded from clinical trials that focused on individuals with an EF less than 35 or 40%. It varied between trials, or individuals with heart failure with preserved EF that had EFs generally below 50%. Consequently, there's very little evidence from clinical trials, at least clinical trials that specifically focused on these patients, to help direct therapy in this population. And guidelines remain virtually silent on how you should treat individuals with heart failure with mildly reduced EF. One even might ask the question, does it really matter? The dogma for many years was that heart failure with reduced EF patients were at much higher clinical at risk for clinical events than patients with heart failure with HFpEF and mid-range or mildly reduced ejection fraction, and that we really ought to be focusing on that reduced ejection fraction. That, I think, is really a erroneous concept. It was developed largely based on populations of patients that were included in clinical trials, which are not entirely representative of the heart failure population at large. This slide looks at the characteristics of heart failure patients according to left ventricular ejection fraction. You'll note that the individuals are separated into reduced, mildly reduced, and preserved ejection fraction, and they're clearly separated according to this arbitrary definition. However, if you look at all of the characteristics of these patients, although there are some differences, and people have written multiple articles about these differences, if you drop back and look at this from the 30,000-foot perspective, what you see is that patients with heart failure tend to be older, and they've got a bundle of comorbidities that go along with them. And that's true of heart failure with mildly reduced ejection fraction, as well as those individuals with heart failure with preserved EF or reduced EF. Perhaps even most important is that when you drop back and look at registry data, which is much more representative of the heart failure population at large and much more representative of the patients that we're seeing in our clinics, we get a very different picture of what the natural history of these three classes of heart failure really look like. So this is registry data from a large European registry and the Get With The Guidelines registry here in the United States. And what we're showing is survival over a 5-year period in patients with HFpEF mildly reduced and heart failure with reduced ejection fraction. And in the European cohort, these curves are virtually superimposable, pointing out, number one, the very high mortality rate in patients with heart failure, and also the fact that one really can't differentiate between these three different classes of heart failure, at least as far as survival is concerned. And this data is virtually replicated in the United States in the Get With The Guidelines survey. Again, we have the three classes of heart failure with reduced, preserved, and mildly reduced ejection fraction. And again, the mortality curves show the significant burden of heart failure and also the poor outcomes in this patient population. And those poor outcomes are present regardless of what class of heart failure that individuals might have. If you think that that may be a little bit distant from what we're seeing here in San Diego, let me convince you that that is not the case. This is some data that we put together for a study that we did where we were looking at the use of machine learning for trying to predict outcomes in patients with heart failure. And we drew out a large cohort of patients from our own EPIC medical record here at UCSD. And we separated these patients, and this is a highly representative population of heart failure patients, and we separated them according to standard definitions for reduced, mildly reduced, and preserved ejection fraction. And we looked at their outcome vis-a-vis survival. And just as was shown in the other registries, what we see here is that there's absolutely no difference. There are three curves in there. The colors represent the 95% confidence intervals, and they overlap almost entirely throughout the period of follow-up in this patient population. Here's some data that really I found very, very illuminative for me. This is data that comes out of also a population-based study. In this case, the population is the Olmsted County population. And this is work done out of the Mayo Clinic in Rochester by Sharon Dunlay. And what she looked at was patients with advanced heart failure. And we virtually always think of advanced heart failure as patients with this very low ejection fraction. In this survey, Dunlay and her colleagues defined advanced heart failure as having debilitating symptoms that were refractory to therapy. It turned out that there were about 13.7% of all the heart failure patients in Olmsted County that could be defined in this way. It turned out that these patients were at high risk of mortality over a period of 12.2 months. About 50% of these patients had died. What was remarkable was that 14.3% of the stage D patients had heart failure in that mildly reduced category. That was somewhat surprising, something that I think many of us had not recognized as occurring. Then when you look at the population, and again, these are the patients with stage D heart failure with those debilitating symptoms, the unrefractory patients, if you look at their outcome, when you separate them according to whether they had mildly reduced, preserved, or reduced ejection fraction, outcomes are virtually identical for both survival as well as hospitalization. So that to me was eye-opening. It also, I think, began to raise, all of the data that I showed began to raise a little bit more interest in the patients in the range of ejection fraction between 40 to 50%, so that over the last couple of years, a working group involving a number of heart failure associations around the world got together and tried to come up with some universal definitions and classification for heart failure. And this is what they came up with. This listing here: heart failure with reduced EF was an LVEF less than 40%. They termed the patients in the mid-range mildly reduced ejection fraction. We used to call them mid-range, and the preferred term now is mildly reduced. And then HFpEF with an EF above 50%. And then heart failure with improved ejection fraction, a really interesting group, which I'll touch on just very briefly in one or two of the slides later on, but a very, very interesting cohort, those individuals who improve their EF over time. But this is the population that we're looking at. To be very honest with you, I was disappointed in this document in that I thought it was parsing at the edges of what was a real problem, and that was how to separate patients with heart failure into groups that were perhaps more clinically meaningful to us. So this slide looks at the pros, and I'll show you the cons in just a moment, of using EF criteria to classify patients with heart failure. There certainly are some advantages. Number one, it's based on historical precedent. It's a very simple way of categorizing heart failure. You take one number, you put patients into a certain category. You can readily obtain left ventricular ejection fraction by echocardiogram. It's available virtually around the world. It's relatively cheap and relatively easy to do. And until recently, the classification of patients based on LVEF could define therapies that were effective. So you had a group of therapies that were effective in heart failure with reduced EF, and you knew that in patients with heart failure with preserved EF, they didn't work and you wouldn't use them. And that gave us some direction in the management of patients. But there are some issues with this classification system. Number one, it's based on outdated concepts of pathophysiology. There's inconsistency in the cut points and the definitions. One would ask the question of whether or not LVEF is the best indicator of contractile function. Again, we've used it synonymously for abnormal systolic function, and there may be better ways of measuring this. And I think now there's also some lack of certainty in categorizing patients according to EF and administering therapy based on that. There's certainly a lot of uncertainty about the management of heart failure with mildly reduced EF. So let's go into a little bit more depth about the problem of using left ventricular ejection fraction to classify patients with heart failure. There are a variety of technical issues, and if you spend some time in the echo lab, you'll be aware of the fact that the echo determination of EF depends on the formula used, on the image that's selected, and the adequacy of the endocardial border that's defined to outline the inner surface of the left ventricle. Consequently, there is considerable intra and inter-observer variability. And that's to say nothing about using tests that are carried out in different laboratories using different machines and so on. There was a recent manuscript that came out that looked at LVEF measurements in a group of patients with heart failure, and LVEF was measured by echo and by other modalities that are currently used, including MRI and some other measures. And it turned out that LVEF was quite variable depending on the measurement that you were using. In addition to these technical issues, there are a whole host of biological issues that are very important. The first being that LVEF depends on the physiologic state of the patient at the time that the measurement is being obtained. And we know that LVEF is load dependent as well as being affected by ischemia. And I want you to think about the patient with tight aortic stenosis, where the LV is facing very, very high afterload during systole. They may have a depressed ejection fraction. And with relief of that obstruction at the aortic valve, when afterload is reduced, ejection fraction dramatically gets better over a very short period of time. Same ventricle, same patient, different EF depending on loading conditions. The use of drugs, both therapeutic and otherwise, can alter left ventricular ejection fraction. A single measurement doesn't account for disease progression over time, and I'll show you a little bit of data about that. And I will submit and show you some clinical trial data that LVEF classification no longer is predictive of the response to therapy, or certainly not as predictive as we thought it has been in the past. Well, let's look at the issue of changes in ejection fraction in individual patients over time. And we'll start out by focusing on this middle column, which shows a cohort of patients with heart failure with mildly reduced ejection fraction. If you repeat their echocardiogram over a period of time, what you'll find is that about a quarter of them have migrated up here to preserved ejection fraction, and somewhere between 30 to 40% have worsened LVEF and fall into the now reduced ejection fraction population. So a lot of egress from the mildly reduced population. At the same time, some of those HFrEF patients are getting better, and some of the HFpEF patients are experiencing a deterioration in left ventricular ejection fraction. This is another survey that Sanjeev Shah presented just a couple of years ago, and it looks at EF changes over time in a patient population that was initially classified as having heart failure with mildly reduced ejection fraction. And what it shows, here's our mildly reduced population, that over time, some of these smiley faces are less happy as they've experienced a deterioration in ejection fraction. And on the other hand, some of them are even happier and their ejection fraction has gotten better over time. So lots of movement in this population, lots of ingress and egress. Well, I think I've covered a fair amount of data fairly quickly, and we might take a break at this point, and might as well take a break with one of the Romantic poets. I've always liked them, and I particularly liked Samuel Taylor Coleridge, who wrote a famous poem called The Rime of the Ancient Mariner. This was about a seaman who went out to sea with his crew. All was going well until one day he picked up his crossbow and shot an albatross, a large bird that had been following the boat. The crew immediately recognized that the good fortune that they had been experiencing during the trip was about to come to the end. And in point of fact, they all ended up drowning, except for the ancient mariner. But before they ran into the storm that ultimately took their lives, they shamed the ancient mariner by hanging the albatross around his neck. And I think that ejection fraction is now the albatross that hangs around the neck of the heart failure community and really is impeding some of our progress in advancing management of patients with heart failure. Well, I've outlined a problem for you, and I think it's really incumbent on me to try to come up with some solution. And I'm not sure that I'm going to be able to do this entirely about how we should classify patients with heart failure, but I'd like to give us all a start about how we should be thinking about this. So in looking at patients with heart failure, as we step back, I think we begin to recognize that there are multiple descriptors of this patient population that would be helpful in trying to classify these patients. These include etiology, genetic issues, including diseases that are monogenetic, also disease mutations or or gene variations that are disease modifying. Comorbid conditions, as I pointed out earlier, is very common in the heart failure population in all aspects of it. And looking at those comorbid conditions, we also know now that there are better measures of cardiac function and additional measures of cardiac structure that can be informative to us in assessing patients with heart failure. We can also risk stratify these patients for future events, and that's quite important because if you look in the categories of heart failure that we have now, there's vast differences in risk in patients who have HFpEF or HFrEF within those classifications. And I think that's important for guiding management. And then finally, I pointed out in an earlier slide that there's a lot of ingress and egress into the mildly reduced EF population. The trajectory of change in ejection fraction can also be used to help better understand and manage this population. Let me give you a couple of examples of some of these things. Etiology matters. This is a population that I've encircled here that was initially identified with heart failure with mildly reduced ejection fraction. The population is subsegmented according to whether they had no ischemic heart disease, they had baseline ischemic heart disease, or they developed ischemic heart disease, that is evidence of either angina or myocardial infarction during the time of follow-up. And these patients were looked at to see whether or not they remained stable, improved, or deteriorated. And the bottom line here is that those individuals without ischemic disease did a lot better than those with either baseline or interim development of ischemic disease. There are a whole host of underlying etiologies which greatly influence the clinical course and management of patients with heart failure. Looked at from the perspective of individuals with mildly reduced ejection fraction, you could classify these different etiologies according to whether recovery is more likely or progression is more likely. And you could list a whole host of diseases. I'm not going to go over any of these in any great depth. I just wanted to use this list as a means of emphasizing the importance of etiology in assessing patients with heart failure, particularly those with mildly reduced EF. We now know that dilated cardiomyopathy is directly caused by gene mutations in somewhere between 10 to 40%. And there are also a whole host of modifying genes that influence the clinical course of these individuals. I think having knowledge of this is very important for guiding management, not only for the patient, but also for helping to educate other members in the family and perhaps identify disease in some of them. Comorbid conditions, I've already mentioned on a couple of occasions during this lecture, how common they are in patients with heart failure of all classes. Here I'm using the example of atrial fibrillation, one of the most common comorbidities, to point out that this particular comorbidity greatly influences the clinical course. Because if you look at the hazard ratio for mortality according to the presence or absence of atrial fibrillation, what you would find was that AFib is a highly powerful independent predictor of outcome in HFpEF, HFrEF, as well as in mildly reduced ejection fraction. In point of fact, it is actually a stronger numerically indicator in the mildly reduced than in the reduced or preserved ejection fraction population. So perhaps a lengthy way of saying comorbidities matter. We need to recognize them and treat them and be aware of them in our patients with heart failure with mildly reduced EF. Now, I mentioned before that ejection fraction may not be the best way of evaluating patients with mildly reduced ejection fraction, and there are better ways available. One of the ways that I think is very promising and actually has been used in a number of different studies now is global longitudinal strain. This measure is available by echocardiogram, and basically what you do is you separate the left ventricle into a number of different segments, and you look at the shortening of those segments and come up with a score for the entire chamber, which is a summation of each of the individual segments. Now, Satit Janvanishtaporn, when he was here, he was a visiting professor from Thailand, spent some time with us, did a very interesting study in which he compared GLS, global longitudinal strain, with LVEF in a population of patients who had recovered ejection fraction. That is, they started out with HFrEF or mildly reduced EF, and they increased their ejection fraction to greater than 50%. And he looked at the distribution of strain and EF in this population. And basically what he showed is that there's pretty close to a scattergram. And if you look at those individuals with an EF greater than 50%, it's no better than the ones down here. So these two variables are not measuring the same thing. He then went on to look at the predictive value of LVEF and GLS in this same population. His primary endpoint was a composite of cardiovascular mortality and heart failure events when he separated the patients according to EF above and below the median. The median here was 52%. EF was absolutely not predictive of outcome, and we looked at a variety of other different endpoints and found the same thing. In contrast, if you use strain as a predictor of outcome and separated the population according to the median value of GLS, you found that it was highly predictive in this population. So strain may be a much better way of trying to get to the root of what's going on in the LV than LVEF is. One other point about global longitudinal strain, this is work that James Miller, one of our residents, and Allison Brand, one of the fellows in cardiology, is doing. They're looking now at patients with heart failure with preserved EF. All of the individuals have an EF greater than 50%. And what they did was looked at global longitudinal strain. This is an ongoing study, but for the patients that have already been entered, and they're shown here in histogram format, those individuals, despite the fact that they had normal EF, many of them have abnormal levels of strain. In fact, the majority of them have abnormal strain. And we're going to be looking at the influence of strain in this population on their subsequent clinical course. So stay tuned for these results. There are other measures of the LV that are important in patients with heart failure. When you classify them according to EF, we're not even looking at these, and I think that's an absence. So if you look at volumes of the left ventricle, are they dilated? Is stroke volume normal? This would be helpful information. Flow and pressure characteristics, intracavity flow dynamics, tissue tracking, giving some idea of strain and strain rates. And finally, very importantly, and an area that I'm very interested in, that is tissue characterization. Is the ventricle stiff? Is there a lot of fibrosis? Is there edema in the ventricle? All of these would be of interest to those of us who take care of heart failure patients on a day-to-day basis. Now, I mentioned before, there's a lot of ingress and egress into the mildly reduced population. And Alison Brand, when she was a resident, did a very, very nice project where she looked at the clinical course of patients with mildly reduced EF, and she separated a large cohort of patients, which she culled out of the EHR here at UCSD, and separated them according to whether or not their EF had come up to the mildly reduced range, or it had deteriorated from a previously higher ejection fraction. And then she used that information to try to differentiate the patients vis-a-vis their subsequent clinical course. And she found out there were substantial differences. In point of fact, those individuals whose EF had improved had come up from below 35% to above 40%, did substantially better than those patients whose ejection fraction had deteriorated. And that was true for the composite of morbidity and mortality, and also for all-cause mortality alone. And then finally, and this is a point that I had mentioned earlier, within each of the classes of heart failure, there's vast differences in risk. What I'm showing here are two ways of assessing risk in a cohort or in different cohorts of patients with mildly reduced EF. One is the biomarker N-terminal proBNP. Look at the differences in risk in the heart failure with mildly reduced ejection fraction population according to quartiles of N-terminal proBNP. The same is true if we use a risk score that we developed here at UCSD. When we looked at those individuals with mildly reduced ejection fraction, this is a risk score that uses 8 very simple clinical variables. You can substantially differentiate outcomes in patients according to whether or not they were at low, intermediate, or high risk. So very useful way of categorizing patients. This is totally overlooked in the classification that we're currently using. Well, I think I'm done beating up on LVEF classification. We're still stuck with a group of patients that have mildly reduced ejection fraction. And I think we need to come back and address the question of what's the best medical therapy for this group of patients. Before I go into this specifically, I had already mentioned there are a group of patients whose ejection fraction improves over time. Many of them improve while they're receiving neurohormonal modulating agents, ACE inhibitors, beta blockers, MRAs, and so on. There's not a lot of information in the medical literature looking at what the effect of taking this medicine off in this patient population, what the impact would be. There is one small study that was published in the Lancet just a couple of years ago, in which a relatively small group of patients were randomly assigned to either withdrawal of therapy or continuation. And it became very clear over a relatively short period of time that those individuals who were withdrawn did substantially less well than those individuals who were maintained on therapy. That to me is convincing evidence, even though it's a small study, that we ought to keep these individuals on guideline-directed medical therapy, even though they've improved their ejection fraction. Well, here are the newest guidelines that came out. They came out just about 2 months ago. They're the ESC guidelines, and they actually now make recommendations. Very first time recommendations for treatment of patients with heart failure actually included some specific drug recommendations. And what they did here was for ACE inhibitors, ARBs, beta blockers, MRA, and the sacubitril/valsartan combination, they grudgingly gave class 2B recommendations. And that really says you may consider this. This is not a ringing endorsement of the use of these drugs in this patient population. And I think we're still left in that situation where we don't quite know what to do, at least based on guidelines. So what I'm going to do is go over some of the data, and I'm going to make what I believe are more realistic recommendations for the management of these patients. And I'll address the question of should drugs with class 1 recommendations for treating HFrEF be used to treat patients with heart failure with mildly reduced EF. And I'll go over the data that's available for the use of beta blockers, MRAs, ARNIs, and SGLT2 inhibitors. We'll start out with the beta blockers. This is the data that's probably the least robust because it's based on a meta-analysis. However, it's a very well done meta-analysis. It's patient-based, and it looks at 11 individual trials. What I've circled here are the individuals whose LVEF was in the mildly reduced range in these clinical trials. And when you look at outcomes, individuals who were treated with beta blocker did better than those individuals who were not on a beta blocker. Very similar outcome to what is seen in the reduced ejection fraction population, and also different from patients who have a higher ejection fraction, in which beta blockers do not appear to convey the beneficial effects as they do in mildly reduced and reduced ejection fraction populations. Let's go on to look at MRAs. I think you're all aware of the TopCat study, which looked at spironolactone, and this was done in a patient population, all of whom had an LVEF greater than 45%. What I'm showing here on this slide are the regional outcomes, which is a very important look at this study because what happened in the Americas is very different from what happened in Eastern Europe. These patients were at much lower risk of developing clinical events compared to patients in the Americas. And at the end of the day, there was a lot of concern that maybe these patients didn't even have heart failure. But if you focus on those individuals from the Americas, what was shown was that there was a modest reduction in the primary outcome that was driven predominantly by a reduction in heart failure hospitalization with spironolactone. Now, Scott Solomon did a very nice post hoc analysis on this database. Entry into the trial was an EF above 45%, and he looked at those individuals who fell between 45 to 50%. What he shows here is the hazard ratio for the primary outcome, which was a composite of morbidity and mortality. If the hazard ratio is above 1, that favors placebo. If it's below 1, it favors spironolactone. This is the line showing efficacy. These are the 95% confidence intervals for the primary outcome, and particularly for heart failure hospitalization. There's evidence of efficacy, certainly in the mildly reduced EF, as well as those individuals with HFpEF going up to an ejection fraction of about 60%. How about the use of the newest neurohormonal modulating agent, that is sacubitril/valsartan combination? We know that this drug works by the combining an angiotensin receptor blocker along with a neprilysin inhibitor. It was first studied in patients with heart failure with reduced ejection fraction in the Paradigm HF study. And in this trial, there was a significant 20% risk reduction with the sacubitril/valsartan combination compared to enalapril. Recently, the Paragon HF study, which looked at LVEF greater than 45%, showed that this combination compared to valsartan alone just missed reaching statistical significance for that same primary composite endpoint of morbidity and mortality. Dr. Solomon again went back and combined the data from these two clinical trials in a construct similar to the one that he used for the MRAs. Again, we're looking here at the hazard ratio. Above would indicate that the ACE inhibitor or ARB was better. Below that the sacubitril/valsartan combination was better. This line points out the efficacy of the drug surrounded by its 95% confidence intervals. Because the two clinical trials span the spectrum of LVEF, we can get a good composite picture across a wide spectrum of LVEF. And what we see here is that up to an EF of about 60%, we're showing evidence of efficacy in improving outcome with the combined sacubitril/valsartan combination. Based on this data, and I think it's very convincing data, the US FDA, not exactly a radical group in making recommendations, as we've learned from the pandemic, went on to opine that the use of this combination to reduce cardiovascular events in heart failure patients was indicated. They do not give an ejection fraction measurement. They say that benefits are most clearly evident below normal. They don't say what normal is, and they certainly don't give a number. And they allow clinicians to make a judgment about the use of this combination in patients with heart failure. How about the new kid on the block, SGLT2 inhibitors? We now know from the Emperor Reduced and the Emperor Preserved trial, which look at individuals with heart failure, regardless of whether they had diabetes, that in each case, the use of the SGLT2 inhibitor was associated with a favorable effect on clinical events. It reduced them in the patients with reduced ejection fraction by 25% and 21% in the HFpEF population. Based on this, I think that one can make a stronger recommendation than the Class 2B recommendation made in the European guidelines for the management of these patients. And I personally would advocate for the management of these individuals with beta blockers, the sacubitril/valsartan combination, an MRA, and an SGLT2 inhibitor. There are some areas, and I'm going to finish up with some areas where I think more information is needed, and that is identifying patients who have an ejection fraction above 35% who are at increased risk of sudden cardiac death. That goes on to ask the companion question is, can we prevent sudden cardiac death in this population? And similarly, many of these patients with EFs in the mildly reduced range have left bundle branch block with a wide QRS. We need some more information about the use of CRT in this patient population. Let me provide a little information that's available. This is from a population of patients whose left ventricular ejection fraction improved. When it was still low, they appropriately had an ICD put in according to guideline recommendations. And basically, some of them improved and they came up for ICD generator replacement. And these investigators asked the question of what happened to those individuals whose EF improved. And they looked at them after the ICD generator replacement because they would have a good measure of whether or not they were having either ventricular tachycardia or fibrillation. And basically what they showed was that there was no difference. What this data, I think, indicates to us is despite improvement in ejection fraction, if somebody has an ICD, unless there's a compelling reason at the time their battery runs out, they should have a generator replacement. Now, managing ICD in patients with heart failure with mildly reduced EF, there's really not much direction in the guidelines because the current guidelines focus on heart failure patients with reduced ejection fraction. And I think that's reasonable because if you look at the incidence of sudden cardiac death in the United States, it's the individuals with low EF who have the highest incidence. If you look at patients with mildly reduced or preserved EF, they're up here somewhere. They have a much, much lower incidence. However, if you look at the total number of events, this is where the events are occurring. Not down here, they're much less common, although in an individual patient, they're much more likely. So the question comes up, can we identify higher risk individuals in this more general population that would identify them as being at increased risk of developing sudden cardiac death? There have been a number of attempts at doing this, including developing risk scores. To be honest with you, they're not very helpful and certainly wouldn't lead to any wide-scale change in how we manage these patients. There are some other promising ways through imaging of the left ventricle. Here's an example of late gadolinium enhancement, which shows areas of fibrosis in individuals with both mildly reduced and preserved ejection fraction. There are either ischemic or non-ischemic patterns. I'm not going to go into that, but simply point out that if you're late gadolinium enhanced positive, you're much more highly likely to experience sudden cardiac death than those individuals who have no late gadolinium enhancement. So maybe we're getting at this question, trying to identify individuals that might benefit from an ICD in the mildly reduced population. Let me finish up now and summarize. Heart failure with mildly reduced ejection fraction is common. There's no really distinct clinical profile, except perhaps there's more coronary disease. The risk of future events is considerable, and in fact, it's virtually identical with reduced and preserved ejection fraction. I strongly feel that the way we classify patients according to EF is suboptimal. I also think that there is more compelling reasons than the guidelines recognize for management with neurohormonal modulating agents, ARNIs, beta blockers, and MRAs, and also SGLT2 inhibitors. And then finally, I would replace batteries in individuals whose EF has improved into this range. So I'm going to finish up at this point. I will point out that at the end of the rainbow, rather than there being a pot of gold. There is a way of getting CME credits. So hopefully I've left some time for some questions in the audience. And thank you so much for allowing me to present this today. Simmerjohn, I think you may be muted. I can't
Having
hear you.
difficulty unmuting myself.
Okay.
You have a question? Yeah. Oh. So, Dr. Jassel, will you be able to ask these questions, or do you want me to? Okay. Dr. Greenberg, people love ENF. How successful do you think we will be in moving beyond it?
Well, I think that, the devil is going to be in the details, but I think that there are ways of looking at a heart failure population that transcends left ventricular ejection fraction. There was a classification that came up, it's about 10 years ago now, that is highly based on a genetic classification called the Moges classification. Elisabetta Arbrostini was the first author on that. It's a bit cumbersome to use, but it's an attempt to go beyond LVEF. I think that incorporation of at least some of the factors that I mentioned, etiologies, comorbidities, gender in a classification is going to be important. And important in that all of these relate to responsiveness to therapy. And I think we need to start looking at heart failure patients in smaller parcels, similar to the way that patients with various malignancies are looked at by our oncology partners.
Thank you. And Dr. Jassel can't unmute herself, so I'll ask the next question. Amazing presentation. Thank you for sharing. I am now thoroughly convinced that EF is not the best classification marker, particularly in those with mildly reduced EF. In terms of future studies, is there an alternative marker or variable you would recommend studies use? Maybe strain?
We've been looking at global longitudinal strain. And I think that's one good way of doing it. But I think incorporation of readily available clinical material that looks at etiology of heart failure, comorbidities, and also establishment of risk. And you can do that by biomarker or using our marker HF risk score, which is, by the way, available on the web, and it's open to everybody to use. I think having that information really helps us make better informed decisions about individuals with heart failure. I'm hoping that over the next couple of years, the group that put together that new definition and classification of heart failure will come together again and provide us with a better classification system that incorporates some of the factors that I went over today in the course of the lecture.
Dr. Greenberg, I apologize for my technical difficulties. Can you hear me now?
I can hear you now.
Excellent. I apologize. From Dr. Rubin, alterations in fatty acid metabolism are associated with CHF. Do these acquired alterations factor more strongly into one type of pattern of CHF? Is treatment targeting these pathways providing any new directions for therapy?
So it's a great question. And I think people are looking at these abnormalities now, and there's specific component to the 3 classes of heart failure that we currently look at, or 4 if you include improved EF, really isn't known. But I think that he's getting at the root of what's going. We need to understand better from a pathophysiologic state of what's happening in our patients with heart failure, and we can be much more directive and much more effective in our treatment.
And that is all of the, oh, one more question. Is there enough data to use the global longitudinal strain method of assessing function to predicting mortality compared to EF?
I would like to use it. I don't think that it's going to be all that widespread. It is difficult. Not everybody is conversant with it, and EF is ingrained in our mind. It's the albatross around our neck, if you will. And I think it's going to take a while for us to unhitch ourselves. What I try to do was to raise awareness about other modalities that are available, whether it's GLS or another individual mortality or another individual variable. I think that will play out over the coming years. But I think that LVEF certainly by itself is not the way to do this.
Thank you so much, Margaret, for stepping in for me. And Dr. Greenberg, thank you so much for that really illuminating presentation. We're so grateful to you for a terrific talk. And my apologies for the technical difficulties.
Oh, thank you, Simrajot. And again, thank you for giving me this opportunity.
I hope all of you will join us again next week for another Department of Medicine Grand Rounds. Thank you.